one of the big questions I think right now that a lot of people have is um, the what it appears is the predominant way that this monkeypox virus transmits or spreads is through um, intimate contact, sexual contact, primarily. Right? We know that touching of clothes that have been infected or bedding that's been infected can also transfer the virus, but primarily it's through this intimate contact. Is there a reason why it's not classified as a sexually transmitted illness, and what do you classify it as instead? Help me understand that.
Absolutely. No, that's a great question. That's something we're really trying to get a better understanding of. We do know, as you said, that this virus is transmitted very effectively through close contact. What we don't know yet is it just the close skin to skin contact, or is it actually transmitted by those fluids, like semen or vaginal fluid? So that's what would determine if this is truly a sexually transmitted infection or not. Something that's transmitted by sex itself or by just the close contact that sex involves. Right now, we just don't know. I mean, I think there's some concern that it may well be sexually transmitted, but we just don't know that yet. And I think we're going to need to see studies looking at, is this virus present in those fluids to know for sure.
Sorry. So can you help me understand then? Is it's transmitted then by touch, right? Of touching somebody that has an infection on them, like that rash, the pimples, the blisters, the sores. Is that the way it's primarily transmitted?
That, as far as we know, from just the historic experience with this virus, yes, that's the primary way it's transmitted, especially if the person has the rash. While the person has the rash, they're the most infectious, and so contact with that rash, with the fluids that come with the rash, is very high risk for exposure. It's just very infectious at that point.
So, and when you say the fluids, do you mean like a discharge coming out of the sores?
Yeah, because they can turn into pustules, and they can drain fluid as well. Typically, even without that, just exposure to the actual skin rash can be enough.
This is going to sound like a stupid question, and you'd think of
No,
somebody
that's
whose
totally
parents
fine.
are medical professionals. I should know this, but if you come into contact with somebody, even accidentally, right? You brush up against somebody, the supermarket or someplace with a large crowd. You don't touch the rash, but you do touch another part of their skin, somewhere where there is no rash. Are you infected or at risk of getting infected if you're not touching the rash itself?
I mean, I think the risk is lower in that instance. The other thing to emphasize is that even if you have contact with someone with monkeypox, it's really close skin-to-skin contact for a prolonged period of time. This isn't, I think the main concern, if you compare this with like respiratory viruses like COVID-19 or influenza, there you can inhale the droplets, and maybe you're just passing by the person or you're in the same room as them, but you're not close by. With this, though, we really think it requires a kind of a prolonged face-to-face time or just skin contact that's probably a little bit longer than just a very brief brushing up against someone. So I would say that sounds like a kind of relatively low-risk situation. At the same time, if someone has the infection, of course, they should be isolating because, even if they have the rash all over their body, it's pretty easy for them to transmit it to other people.
You mentioned isolation. We've heard that term so much with COVID-19, but monkeypox is a different virus, as we've just talked about. What is the quarantine or isolation time for somebody who is either infected or a close contact?
Absolutely, that's a great question. So what I would say, first of all, is for people who are exposed to someone with monkeypox, they don't have to quarantine. So unlike COVID-19, where if you're kind of exposed to someone with COVID-19, you have to quarantine until you can test to make sure you don't have it. In this case, you don't have to quarantine if you've been exposed, but you do have to monitor very closely for any symptoms. And as soon as you have any symptoms, then you should isolate yourself. The symptoms, of course, can start about a week to 2 weeks after the exposure. So it can take quite a bit longer to develop symptoms. And when you do develop symptoms, then of course, you should isolate because the initial symptoms can be they're not specific to monkeypox, right? There are things like fevers, muscle aches, chills. And so those things it could be other things as well. But certainly when you develop the rash typically starts about 5 days after the other symptoms. The rash, of course, when you have that, then you should definitely be in isolation because that's when you're most infectious. The good thing about monkeypox, unlike COVID-19, is that almost everybody who gets the infection gets symptoms. This isn't where with COVID-19, where some people had no symptoms, but yet we're still transmitting it. So from a perspective of like controlling the spread of this infection, the advantage there is that people know they're sick, and so they can isolate and hopefully prevent infecting other people.
And what is that isolation period of time again? I'm sorry.
So it can vary by patient. It depends on how long they have the rash, but typically it can be 2 to 3 weeks. But the key is that the rash has to completely resolve. So all those pustules, all those areas, they have to kind of crust over and fall off. And then the new skin underneath should be there. And once that's happened, all the lesions have gone away, all the wounds are gone, then the person is considered not infectious anymore.
Are there any topical treatments for those pustules or sores? I mean, I know there's the vaccine, right? But that's not a topical treatment. Are there any that doctors are encouraging for people if they say they go through the process, right? That they get the vaccine and then they've got to isolate for 2 to 3 weeks. Is there anything else they can do on top of it?
Yeah, so there aren't any topical treatments specific for the virus. There is an antiviral, which is available as pills and as an IV. That is definitely an option for people who are more sick, who have more severe infection. There isn't any sort of topical antiviral medicine. So the topical treatments would really be to treat the symptoms, keep taking care of the skin, but not any sort of antiviral.
What's the name of the antiviral pill that you had mentioned?
Yeah, so tecovirimat is the antiviral that was developed as a treatment for smallpox. But there's some evidence that suggests it is an effective treatment against monkeypox as well. It's available through the Strategic National Stockpile, so the federal government has supplies of it. They are distributing it to states across the country. The Maine CDC has received supplies, and they've sent it on to the other hospitals across the state. And that is something that we can provide people if they're either have severe illness or they're at high risk for severe illness because of their underlying medical conditions. That's a treatment we can provide to them. We can prescribe it, we can monitor them while they're on the treatment, and then we can see that treatment should help with the severity of the infection.
But that's only something that would be taken post exposure, right? You couldn't take it preventatively.
No, so this treatment is really meant for people who have monkeypox and who are very ill. Whereas the vaccine can be used preventatively after someone's been exposed. That's kind of in relation to your question about exposure. After you're exposed to someone with monkeypox, over the next few days, if you get the vaccine, well, within 4 days after the exposure, you can prevent developing the infection. So that if that person gets vaccinated right away, they can avoid getting the infection. Now, if they get vaccinated, but say later than when they were exposed, so say a week after the exposure, they might still get monkeypox, but the vaccine can reduce the severity of the infection. So that's really where the Maine CDC and federal CDC has been encouraging its use, is really to vaccinate contacts of people who have monkeypox to try to prevent them from getting it or from getting really sick with it.
Okay, understood. When we talk about the vaccine, right now the state has what they call it 751 first doses. So similar to COVID-19 or any other really vaccine, right? You need 2 of these. Many vaccines require a course,
Absolutely.
right? So I don't need to tell you that. You're the infectious disease expert. No, but 751 first doses is how they're qualifying this right now. Given the number of confirmed cases that we have in the state, one in York County, one in Penobscot County, and one in Aroostook County, do you feel that will be? Dr. Shaw told me a couple of weeks ago, before we even had cases number 2 and 3, he's like, I don't think that's going to be enough. We're going to need to get more from the federal government, which they are. Do you share that kind of sentiment? Do you feel like we need to get more doses from the federal government in order to prevent the spread?
Yeah, I mean, absolutely. I think that it's a challenge because there's limited supply of the vaccine available, but it is definitely something that we'd like to see. We are expected to get more supplies of the vaccine in the weeks ahead. The hope is that we would get much more vaccine and that we'd be able to vaccinate a larger group of people, especially moving past just vaccinating people who have been exposed to someone with monkeypox, moving to where we can vaccinate people who are at high risk of being exposed and therefore actually prevent them from even getting any risk of getting monkeypox. So yeah, I mean, I think I totally agree with Dr. Shah. I think that we'd like to see more vaccine, and the hope is in the weeks and certainly in the months to come, more vaccine will be manufactured, we'll get more doses, and we can kind of be a bit more broader with who can get the vaccine.
When we talk about people who are at a higher risk or a relative increased risk, right now the evidence, the epidemiological evidence is showing that men who have sex with men are at that increased relative risk. Are there any other groups that you see right now that would be at an increased relative risk compared to the general population? Because what we've been told so far by other public health experts is that to the general population, the risk is low, but to that one specific group, there is an increased relative risk. So are there others, or is it just that one population?
There are others. I think people who have severe skin diseases would be important because while they might not be at high risk of acquiring the virus, if they get it, they would be more likely to get severely ill. People with medical conditions that weaken their immune system. So people with HIV, for example, who aren't on treatment for the HIV can be at high risk as well. And then people with other conditions that weaken their immune system might be something to consider for them. There are some the vaccine, there has to be some kind of considerations for like safety of the vaccine and so with people who have really compromised immune systems. But generally speaking, the Jynneos vaccine, which is the one that's currently being made available, is quite safe and has a pretty good track record in the studies that happened. I mean, it hasn't been given kind of to a wide range of people because we've not had smallpox since the vaccine's been developed. But everything we know about it is that it is relatively safe and that it can be an option for people who are in those risk groups.
I'm just going to kind of keep going here through a couple of questions. Is there a test for monkeypox similar to how we have nasal swabs for COVID-19? I know that they're different viruses, but is there a test for it?
Absolutely. So right now there isn't any test that you can do at home by yourself. So what typically the testing involves is having a doctor swab several of the skin wounds that you have, the pustules, and then send those swabs off for PCR testing. So kind of like your PCR test for COVID. They would send it to a lab. The lab would process that and see if there's any evidence of the DNA of the virus in there. That's really the mainstay of testing at this point. There are other tests available, blood tests and the like, but we haven't really been using those, and we don't know yet how reliable those tests are. But certainly, the swabs of the actual of the skin wounds are the kind of the go-to test.
So really, someone would have to present with those skin wounds in order to have an indication that they are more likely to have monkeypox.
Exactly. I mean, we've certainly been encouraging people to to see their doctor by telehealth perhaps at first and go over the symptoms with them, and then they would need to bring the person in then to get the tests. Unfortunately, there's no way to swab yourself at home, at least at this time. That might change in the future, but that's kind of what we're looking at. But if someone has a concern, their doctor can work with them to tell them how to come to the clinic, make sure that they're covering up all their skin wounds, making sure they're wearing a mask, and kind of adhering to all those things to avoid exposing other patients.
Kind of a pre-screening process to kind of go through a person's, even potentially their sexual health history to see if they would kind of fit the increased risk profile.
Yeah,
Okay.
or even just calling your doctor's office before you go in,
Right.
just to make sure they're aware that this is something you're concerned about.
Got it. Okay. All right. So I have two. Actually, I have three more. Give me 1 second. I'm gonna write this down so I don't forget it. I know that monkeypox, completely different virus than is COVID-19, right? Yes, you can't. I guess CDC is saying you can spread this virus through some respiratory droplets, but not in the same way that we saw COVID-19.
Exactly.
It's not the primary transmission mode. But
Exactly.
I think there are some people who maybe are not as educated in public health who are asking the question, boy, now that the World Health Organization and the White House have now called this a public health emergency, are we going to be going back to kind of the early days of the COVID-19 pandemic where we're masking, isolating, working at home again, not going out? Do you see that happening, or is that not the case here?
No, I don't anticipate that. I really think that this virus doesn't have the capability of becoming a global pandemic the same way that COVID-19 does. There are no absolutes, of course, and this could change. But given what we're seeing right now, I think that we're seeing a virus that is a lot less infectious than COVID-19. And so I don't anticipate us having to do kind of these wider public health measures like restricting capacity at venues, having people work from home. I don't anticipate that. Again, I do think though that people with any symptoms of any infection shouldn't be going into work, going into public places. But I don't anticipate us having to do those sorts of measures just because this isn't going to be as broad a spread around the world the way that we did with COVID-19. At least that's what I anticipate.
Understood. There was actually a viewer had sent us this question saying, because monkeypox is of a similar family of smallpox virus, is that right?
Yes.
So they had asked, if I've received a smallpox vaccine, does that protect me at all against potentially getting monkeypox? What do you
That's a
think
great
about that?
question. Yeah. So we think that probably, yes, that person probably has some protection. The challenge is we don't know how long the effectiveness of the smallpox vaccine lasts against monkeypox. So if the person got that vaccine 40 or 50 years ago, they may have some protection. So if they were to get the infection, maybe they wouldn't get as sick. But whether they still have enough protection to prevent getting the infection, we don't know that. So certainly if they're a high risk individual, like in the high risk group, then even though they had it at birth or when they were younger, they may still want to get a dose now. Or if they're not at high risk of exposure, then they may not need to get any further vaccination.
When we talked about it just a second ago, but the World Health Organization and the Biden administration declaring this a public health emergency. When we had it with COVID-19, it did take a while to kind of reach that point. What's your reaction to how soon those two organizations and entities declared this a public health emergency? Was it surprising to you or no?
No, and I think it was the right move because I do think that even though, again, as I mentioned before, this isn't a global pandemic, there isn't this extensive spread of this infection all over the world. I mean, it certainly is all over the world, and there are cases in many countries, but it hasn't been as widespread. At the same time, I do think the public health emergency declaration allows for more resources to be shifted to the response. And so while I don't think that the entire country, for the United States at least, is at the same level of risk, I do think that cities like New York City, San Francisco, others that have had big outbreaks, I think that that really is helpful for them in being able to kind of mobilize resources, get people the supplies they need, get the vaccines out there. I think for that, in that respect, I think it's helpful. But I don't think that we're necessarily at the point where this is like a widespread infection everywhere, right? And as you said, in Maine, we probably will see more cases. 3 cases is probably not the end of it. But at the same time, I don't think we in Maine are at that point. Of course, our Dr. Shaw and the Maine CDC team will make that determination if we get to that point. But I think that it varies based on where you are.
Dr. Abel, you have answered all of my questions and you've been very generous with your time. Is there anything that we haven't covered that you feel like we really need to make sure we hit on?
No, I think that's everything. I just again reassure people that the overall risk to the general public is still low. At the same time, we want to be vigilant for if you or someone you know has any symptoms that are concerning for monkeypox, and a rash that's concerning, then I would definitely recommend people call their doctor and see if they should get tested.
May I ask you, one more question that kind of came to mind when we were when we were covering the first case, the first confirmed case of this. You know, bluntly, right? There was that one population that is of the increased relative risk, and so we actually reached out to the Franny Peabody Center down in the Portland area, the HIV/AIDS kind of outreach center, and to talk to them about the potential for stigmatization around this, in the fact that there is one group that is at an increased relative risk. How have you been addressing this with your fellow physicians, potentially any patients, about avoiding stigmatization?
Absolutely. And that's a very important point. The thing here is I think we do have to acknowledge that this one group of people, men who have sex with other men, have been at higher risk during this outbreak. They've had the majority of the cases in that community. At the same time, we have to recognize that all of the disease is spreading very quickly in that population, that there isn't necessarily anything about that group of people that makes them at high risk. Now, perhaps in terms of transmission, there may be some higher risk, but really the key is to emphasize that anybody can get monkeypox if they have an exposure to someone with it. And I think the key there is using their knowledge of who's at risk to guide preventative efforts. So reaching out to those advocacy groups that work with these communities to make sure that we're doing all that we can to get people a vaccine, get people treatment, but at the same time, not using this as an opportunity to stigmatize that population, right? Really emphasizing that if one group of people is at risk, we focus our efforts there, but we emphasize that there's anyone else can still get this virus, right? So I think we have to strike a balance here, and that's what I've been trying to do in terms of my messaging around this to patients and to other providers, other doctors.
Dr. Abel, you're a rock star. I really appreciate all of your time. Amy, is there